Welcome to AETCM, the emergency medicine channel. Shall I?
Yeah, sure.
Today we will be discussing a case of 58-year-old male patient, known case of CLD with portal hypertension, presenting to ER with 2 episodes of hematemesis and 1 episode of melena.
Okay.
On 10-second assessment, patient is conscious and obeying commands. On primary survey, airway is patent, no secretions, gurgling, hoarseness of voice and stridor. Breathing, maintaining saturation of 98% at room air with a respiratory rate of 18 per minute and air entry bilaterally equal. There is no added sounds. Circulation, BP is 140-80 mmHg with a heart rate of 115 per minute. Peripheral pulsations felt bilaterally equal. At this time, 2 large bore IV cannulas were inserted. Disability, GCS is 15 by 15, pupils 3 mm bilaterally equal and reactive, GRBS was 150 mg per deciliter. On exposure, temperature is afebrile. Adjuvants to the primary survey, ABG was taken which showed a pH of 7.38, carbon dioxide 36.8, bicarbonate 23, lactate of 5.4. We have also ordered for a CBC CRP in which the total counts were normal and CRP was 4, HB was 8.4, platelet count 80,000 and INR was 2.1. We had sent for blood grouping and cross matching.
Okay. So basically we have a 56-year-old male who has come to the ED with episodes of hematemesis. So 56-year-old with hematemesis. Since when he is having hematemesis? Since last
2 days.
Last 2 days he is having hematemesis. Okay, basically it's a case of chronic liver disease. So from this background itself, we are almost sure that we are going to deal with a patient with variceal bleeding. So that's in the background. So what are the main challenges when such patient comes to the ED? You start with the airway, breathing, circulation. So what will be, as an ED physician, what are the basic challenges that we will have? Airway challenges in case of a hematemesis. We'll start off with that.
Whether there is any secretions or...
Definitely there is secretions. He's having vomiting. So what will be the most important thing? That he'll aspirate. So when will you decide, okay, this patient requires intubation? I'm just saying that because of hematemesis, you are planning for an intubation. Will you do that?
If the sensorium is very low.
Okay, so the chronic liver disease patient, they are prone to develop hepatic encephalopathy also. That is one of the triggers for your hepatic encephalopathy also. So when the sensorium is borderline, he is having hematemesis, definitely you need to secure airway early. There is no sensorium, say like GCS of 10, 12, there is nothing like that. It all depends upon the clinical assessment during that time. Less than 8, definitely we will go ahead if there is hematemesis there or not. But here the risk is high. So we have to evaluate the patient, maybe a GCS of 12, maybe GCS of 13, we need to early intubate him. Maybe with the normal GCS also, sometimes we will be forced to intubate the patient early because there are 2 reasons why you want to intubate. One is, as you said, aspiration, and definitely we don't wanted to have an evaluation and treatment of the hematemesis, endoscopy also. So when you are intubating the patient, you are securing the airway already. So while doing endoscopy, the chance of vomiting, everything we can decrease. So that is the 2 reasons why we want to secure the airway, and next one will be to make endoscopy a little bit easier thing. So that is the challenges that we will have in the airway. And breathing, they would have already aspirated. So that is the another big challenge. They would have already aspirated. Already they might be having a pneumonia, aspiration pneumonia or pneumonitis. The blood would have gone into the lungs, and hypoxia you need to treat. So at that time, oxygenation is the most important thing that you need to keep into your consideration. So the patient came. Next challenge is into the circulation. So what all things can happen in circulation? The most common one, the patient can go for an hemorrhagic shock. But what is the category of hemorrhagic shock that the patient has gone in here?
The patient has a third category because there
is no hypotension.
No, there is no hypertension.
But there is only tachycardia. So maybe a class 2 hemorrhagic shock we can call. There is no hypotension as such. Maybe a class 2 only tachycardia is there. So, and what another striking thing that I got in is the lactate level. Lactate level is 5.3. So how will you infer this elevated lactate?
CLD patient.
Okay, CLD
there
patients.
Can be a hyperlactemia.
Why there is hyperlactemia? Because simple thing, lactate clearance
is not
will
there.
get affected because of the liver dysfunction. So that is one reason. Second reason being hypotension. If there is lactate, increase in lactate, how does lactate increase? What are the reasons for an increased lactate? Rather than we cannot say it as a lactic acidosis in this patient, because there is only hyperlactemia. There is no lactic acidosis as such. So when we call it hyperlactemia more than 2 lactate, we can call it as hyperlactemia. So this patient is having hyperlactemia. One reason you said lactate clearance is getting affected. Second reason could be what? What are the types of lactic acidosis that you should know? What would be the next reason for an increased lactate? What would be the other reason? Perfusion. Tissue perfusion getting affected. So tissue perfusion, even if there is no hypotension as such, but there is some amount of compromise in the tissue hypoperfusion. So that might be the reason for the increased lactate. Then what is the other reason? What will happen in a sepsis? Do you really rely upon a CRP level in a patient with liver disease? You can't. Because CRP you cannot trust upon always. Because CRP sometimes can be very low in a patient with liver disease. You cannot rely upon a CRP value. Maybe an underlying sepsis, we don't know. Already he would have aspirated since last 2 days. He's having this multiple episode of vomiting, hematemesis and all those things. Maybe already he had developed an GI sepsis, spontaneous bacterial peritonitis, or he can have aspiration pneumonia. We don't know. So sepsis, what is the background of lactic acidosis or hyperlactemia? What is the reason you will have in sepsis? It is basically the endotoxins or whatever be the toxin, they will cause mitochondrial dysfunction, causing increasing lactate. So these are the multiple things that you need to keep in your mind. When you see an increased lactate level in this patient, you need, okay, what could be the reason number 1, reason number 2, reason number 3. Then you need to answer to all those things. So one striking thing was tachycardia. And another striking thing that you should keep in your mind is that usually chronic liver disease patient, they might be on some beta blockers. If he is on beta blocker and with a heart rate of 115, that means with beta blocker, he is having a tachycardia. So why they will be on beta blockers? Chronic liver disease patient. To decrease the portal pressures. So portal hypertension, if there are different categories, like 5 to 10 mm of Hg, they will be on beta blockers. So now the recommended, previously we used to give propranolol. Now if there is no features of decompensation, if you have gone for any time decompensation like hepatic encephalopathy, that is contraindicated. Beta blockers can precipitate further hepatic encephalopathy, but if he has never decompensated, then we can go ahead with beta blockers. Now the agent of choice is carvedilol. So carvedilol, the patients are, they might be on carvedilol. So on carvedilol, we don't know, we haven't seen the drug history here. On carvedilol, you just imagine his heart rate is 115. That means the heart rate is too much. So he's going for an hypotension at any point of time. The next thing, what investigation that you did in circulation wise, what you did was an CBC and hemoglobin is 8.4. So what will be your target? What is your target for to start arranging for blood?
7, less than
7 gram per deciliter. If the patient is having some coronary artery disease, the target should be little bit high. As per the evidences recently, it is 8 they are suggesting to keep hemoglobin above 8. Preferably above 10 will be ideal, but above 8 is also acceptable. So if you wanted to plan for an OGD-scopy or anything, 8.2 is okay. You don't need to transfuse it immediately. Hematocrit is got any significance in patient with bleeding like this?
Yes.
What will happen in case of blood volume loss? What will happen to the hematocrit?
Concentration will be there.
So you will have increased hematocrit. So if the hematocrit is very high, that itself shows that you have lost, there are a lot of chance of hemo concentration. So 8.3 we are okay with it. Maybe you can arrange blood and keep it ready. At any point of time, he will go in for requiring a blood transfusion. So that is one thing. Then you said regarding INR. INR, what was the INR for this patient?
INR is 2.1.
Okay. So 2.1 INR, do you want to do anything for that INR? Roll for any FFP, vitamin K? You want to give anything?
No.
You don't want to give anything? No. Okay. So what you can do is that basically when you are seeing a coagulopathy, it is ideal you can give a vitamin K or maybe an FFP depending upon the severity of coagulopathy. If the coagulopathy is severe, definitely yes, you need to give those things to the patient. So FFP correction, that has to be arranged, and preferably I will say to give FFP for these patients that is coming with upper GI bleed. So that is the next important thing that you need to keep in your mind. So that is regarding your blood transfusion and blood product transfusion. Now, the patient has come to the ED. Right now, he is having active hematemesis. You have went through the primary survey. The patient is stable right now. What are the interventions that you want to do? Can you brief upon the interventions?
Medical.
Medical management. So, most probably we are dealing with a variceal bleed. Maybe last endoscopy report will be available for him with a background of chronic liver disease. So, variceal bleed is what? Yes. So, variceal bleed, first we'll discuss how will you manage a variceal bleed, then we'll go for a non-variceal bleed management. So, variceal bleed management, you can explain.
We'll give a proton pump inhibitor on top. 80 mg stat will give, followed by an infusion of 8 mg per hour.
Okay.
Then we could give vasoconstrictors such as octreotide or terlipressin. Octreotide we give 50 microgram stat, which is followed by 50 micrograms per hour infusion.
Okay.
Then we could go for a motility drug, that is perinom.
Okay.
Then we could give an antibiotic.
Okay, so now we'll just wait. I'll just come back to the first drug that you said. You said you wanted to give pantoprazole stat, that I agree. But infusion is not generally recommended for variceal bleeding. It is not needed as such. Because when you see that variceal bleeding, it's just a variceal bleeding. Variceal bleeding, they just need a normal stress dose of your proton pump inhibitor, maybe a 40 mg OD or BD. That is more than enough. So routinely, we doesn't need an infusion unless and until you are having a variceal ulcer bleeding. Variceal ulcer would have caused a bleeding. For a non-variceal bleeding, definitely you need to give proton pump inhibitor. But for a variceal bleeding, routinely a pantoprazole infusion is not recommended. Maybe a bolus dose is enough, and maybe 40 BDs, that should be sufficient enough. So that is one thing. Then you said regarding the next agent, that is the most important, terlipressin and octreotide. Terlipressin has got a superior effect when especially if the patient has got an hepatorenal syndrome and all, and that has got a superior effect over octreotide. And but the cost factor is a little bit too much when you compare with octreotide. So octreotide, you can give a 100 microgram stat followed by 50 microgram per hour infusion. So that is the octreotide. And how long you need to continue this octreotide? Till you are stopping the bleeding. Once you are doing the endoscopy and you have done the banding, that's it. You can stop octreotide. No need to continue beyond that. So maybe you have already diluted something, you can just finish off those doses and just stop that. So that is regarding your octreotide and terlipressin. And coming to the next agent that you said is antiemetic, perinom. You can give antiemetic. Advantages of perinom being that will aid for endoscopy also. Being a prokinetic agent, if you are giving perinom, it will aid in clearing the gastric contents also. That is the perinom's effect. Then next thing regarding antibiotics. So antibiotics, how will you choose an antibiotic in an upper GI bleed? So it all depends upon, again, variceal and non-variceal bleeding. You can again risk stratify the patient. If he had previous multiple episode of hospital admission and he had probably a GNB sepsis and all, at that time we cannot wait for him to develop into a gram-negative septicemia. Maybe you can go ahead and start on a piperacillin tazobactam or even a carbapenem. So that all depends upon the risk factor for the patient. If it's the first episode of hematemesis, basically a ceftriaxone should be more than enough. But it all depends upon the antibiogram. What is the susceptible organism in your hospital? Preferably for our regimen, we prefer to give ceftriaxone sulbactam, that is Magnex. That is what preferred in as per our antibiogram. That is the reason majority of them are receiving this Magnus antibiotic. And if he is developing like already in grade 3 or grade 4 encephalopathy, already there is some spontaneous bacterial peritonitis evidences and all, you can straight away go ahead with piperacillin tazobactam or even meropenem for those group of patients, selective group of patients. For this patient, maybe I prefer either ceftriaxone or a cefpiracillin sulbactam initially, or non-variceal bleeding we will discuss during that time. So that is what you have to do for this. Now, when will you plan for the endoscopy? So how will you decide, okay, which patient require immediate endoscopy? Okay, this patient require an immediate endoscopy. Should ask the gastroenterologist to come and do in the ED itself. So which group of patients you will ask for that?
Ongoing hematemesis from the ER.
Okay.
There is a severe HB drop from the previous.
Okay. So definitely all GI bleed patients require an endoscopy within the next 24 hours. So that is mandatory. So as you rightly said, if the patient has got multiple episodes of hematemesis, even after giving all these drugs, he is having hemoglobin drop, definitely you need an early endoscopy. And do you have any scoring system to say that, okay, this group of patients require an early endoscopy? What is Glasgow-Blatchford scale?
Score is there. Need for the endoscopy intervention.
Yes.
So it's based on the levels of the urea, then levels of hemoglobin, blood pressure, pulse rate, melena, syncope, any hepatic disease or cardiac failure.
So maximum score what you can have is 17.
17.
Yeah.
Score more than 8 needs intervention.
So that's what you need to remember. You can call up you can calculate this key and say that the scoring is high and you need an early endoscopy. So you need some evidences to say that okay, this patient requires an emergency endoscopy. You cannot ship him to the endoscopy suite. You need to come down with your endoscopy, portable endoscopy, and get it done in the ED itself. So that is the way by which you can approach. So as an emergency physician, our concern is airway, breathing, circulation, and till maybe the 6 hours till the endoscopy is done, and later on they will take over and whatever is needed will be handed over. But remember that these patients can decompensate at any point of time, so they can go in for suddenly hepatic encephalopathy. So these are all precipitation factors. So all other management aspects like lactulose and all those things you should be continuing. And Riles 2, no role for Riles 2. That is the one thing that you can remember. Riles tube is not at all indicated these days, and especially when you are thinking of a varicose bleed, that post-varicose banding bleeds and all, never ever put Riles tube. Already there would have some clips. Your one clip would have gone. One you are going to put the Riles tube again, the other 2 or 3 clips will get away, and it will be in more trouble. So post endoscopy definitely not. Before also we see every day 4-5 hematemesis here every day. So we don't have an practice of putting a Riles tube. That is not required. Previously there was a statement it will aid them in doing endoscopy and all, but that's all not required these days. So that gives up a summary regarding your variceal bleeds. Now we go ahead to the non-variceal bleeds. So non-variceal bleed, the most of them will be either a gastric ulcer or a duodenal ulcer or bleed, or maybe a malarious tear. So these are the 3 most common. And angiodysplasia and all, maybe you are seeing some 100 or 200 cases, maybe 1 or 2 might come in, because since we in a tertiary care center, we might able to see a lot of these sort of cases. That doesn't mean that the entire population, the angiodysplasias are more. Basically, most commonly they will be on some antiplatelet agents. So they will be either on ecosprin, or they might be taking some NSAID, steroids and all those things. Some erosive gastritis can cause a hematemesis followed by an ulcer bleed. So for those group of patients, definitely we can go ahead with the pantoprazole infusion regimen, whatever you have suggested. And there again, their index of developing a sepsis is slow. Maybe we do not want a higher source of antibiotics like piperacillin tazobactam, maybe a quinolones, ofloxacin, or maybe placing cefuroxime, ceftriaxone will be more than enough for these group of patients. That is non-varicose, and routinely we just know that it is no compound, is just an ulcer bleed. Maybe an antibiotic is also not usually recommended, not needed, but since the blood is there in the abdomen, there is a chance of getting infection. You can go ahead with an basic antibiotic regimen like ofloxacin, a gram-negative coverage agent you can give. So that is all that is required for those group of patients. And again, you can use your Glasgow blood spot scaling, and the hemoglobin levels are the same. Like what we said, no role for your octreotide or terlipressin. But dilemma comes when the patient is coming for the first time with hematemesis into the ED. So whether to treat like an GI bleed, varicose, non-varicose. So then you can use your other tool, get an ultrasound done, just see whether there is any features of CLD. So if we feel that it's a chronic liver disease, usually ulcer bleeds, they will present with melena and coffee ground vomitus. The fresh blood is usually esophageal varices, but you can have in malarious tear also. So that's the young male who had multiple episodes of vomiting, then he is coming. So you are suspecting a malarious tear in that patient. You are not suspecting anything else. An elderly gentleman who is not on alcohol or no other risk factor, who is on antiplatelets, coming to you with an melena and HB drop. So definitely you're thinking in terms of an ulcer bleed. So these things you should keep in your mind. History, along with that, that's the first episode. If the patient is a known case, then it's a very straightforward thing. But always remember, there can be multiple reasons. Previously, an ulcer patient can come with a varicose bleed. A varicose bleed can come with an ulcer bleed also. So keep all those things in your mind. And early endoscopy intervention is what is mostly required. 24 hours ideally they should be taking for the endoscopy. That part you need to convince them, but here the gastroenterologists are so proactive that they are ready to do within 12 hours or 6 hours. They are ready to come and do in the ED at any point of time. So that is the advantage that we have. We got to get a strong backup with them, and once they come in, they will decide what is the definitive treatment, whether it's banding, ligation, argon, laser therapy. That is not needed for an emergency physician. So what our primary aim will be: airway, breathing, circulation, stabilization, hemoglobin, an early intubation, and whom you should refer them immediately for an early endoscopy, and what are the initial 6 hours of management that you need to do, and blood transfusion, when to give platelet transfusion, FFP transfusion, whom all needs vitamin K, all those things is what we need to arrange and start doing things, because they might take some time to come in. Before that, we need to stabilize and keep them ready. Anything else that you need to add on here? Anything else that we missed upon, or you wanted to discuss?
No.
That's it. So, in a nutshell, a GI bleed, it's a pretty straightforward management aspects. Drugs, only 2 or 3 drugs that what we need to remember in the management. Only issue is that if the patient is a known CLD patient, the risk factors are a little bit on the higher side, so that can precipitate your hepatic encephalopathy. So that part you should be very much aware of. Suppose the patient anti hepatic encephalopathy measures also you need to start at. Okay, thank you.
Thank you.